appreciate you joining on fairly short notice. We are dealing with a nationwide blood shortage, and it is impacting us here in Utah to the levels we felt it was necessary to bring these organizations together and offer this collaborative message about the need for blood donors here in the state of Utah that's going to take us through the summer. We're going to hear from these organizations and representatives, and then we'll go through our list here, and then we'll open it up for questions and answers. So let me introduce our order, and then we'll begin. First to join us is going to be Dr. Rob Ferguson from Intermountain Healthcare. Dr. Ferguson is the Senior Medical Director of Surgical Operations at Intermountain Healthcare. We will be joined by Dr. Ram Narula from University of Utah Health. He is running late, but he will be joining us. He is the Chief of the Division of General Surgery at University of Utah Health. From ARUP Blood Services, we'll be joined by Deborah Jordan, Community Relations Supervisor at ARUP Blood Services. And then we'll hear from Benjamin Donner, who is the Executive Director of the American Red Cross of Utah. And also we wanted to add a few patient perspectives, and we really appreciate David Beverly and Peter Beverly joining us. They are going to be participating in a living donor organ transplant procedure at Intermountain Medical Center later this month. Their procedure was actually scheduled for last week, and because of the shortage of blood and the low inventory, their procedure was actually delayed. And so we thought it was very important for people to understand these are patients, these are people who we're talking about who require and need these blood products in order to survive and to be cared for at hospitals throughout the state. So we thought it was vital to hear from them. So first we'll hear from David Beverly, and then we'll hear from his dad, Peter Beverly. They are together. And then we'll open it up for questions and answers. And then at the conclusion of our English-speaking press briefing, we'll go right into our Spanish-speaking portion of the press briefing. And we have Dr. Wing Province, who's an emergency medicine physician at Intermountain Healthcare. And he'll be joined by Dr. Julio Delgado, who's Executive Vice President at ARUP Laboratories. And we'll do that in Spanish as a Spanish-speaking press conference. So with further clarification not needed, Dr. Ferguson, let's go ahead and begin with you. Why don't you give us an assessment of the situation and how it's impacting your world, which is surgeries, procedures that are occurring, and what we're facing right now in terms of the volume of inventories and the need.
Thanks very much, Jess. And thank you everybody for being here. And especially thank you to David and Peter for being willing to come in also. Be able to share from a patient's perspective the impact that this is having. When we have a trauma, there can be disruption of the actual anatomy that causes then bleeding from blood vessels and vital parts of the human body. Surgery is a trauma. It is a controlled trauma, and it's an intentional trauma with the intent of having a therapeutic outcome. And because of the fact that it is a controlled trauma and we have wonderful techniques, over the years, we have less and less blood loss that is happening because of the fact that our techniques have been improving. Patients have need for blood when they lose blood from that type of a trauma, or when they have a medical condition that doesn't allow for their body to have the normal pathway that stops bleeding. We can have some specific procedures in which there are certain organs of the body that just tend to have a lot of bleeding, and we still would need to have blood products available to help that patient get through the operation and the recovery. We can also have patients that have variations in their anatomy that can be a result of bleeding because of some unexpected positioning of blood vessels, and they can also have certain states of the body in which there is bleeding more readily present that would require more blood products than would be anticipated. So as a result, when we have some procedures like, for example, a cardiac procedure or a transplant procedure, that going into that operation, we know that there's a possibility in which the medical condition of that patient, as well as the physical trauma that is inherent to the surgery, has potential to cause bleeding enough where the body needs some assistance in order to be able to recover from that procedure. On top of this, we have the occupational hazard of unexpected trauma that can come to our facility that those patients, because of physical damage to their body, do require blood products. We had a situation there for a couple weekends ago where we had some trauma patients that just required a lot of blood, and a patient that was in a medical condition that added to the trauma that required a lot of blood products. So this caused us to have to make a difficult decision of the safe thing to do in some patients that could potentially be managed in a medical fashion and postpone their surgery until we were able to have enough supply of blood products on hand that would allow for a potential resuscitation or delivery of blood products in the event they required it during their surgery. And so we were having to make decisions, particularly in cases of cardiac surgery as well as transplant surgery, if there are situations in which patients would be able to still be safely managed medically for a couple of weeks until we're able to get our blood supply back up to speed.
Thank you, Dr. Ferguson. Now we'll be joined by Dr. Ram Narula, Chief of the Division of General Surgery at University of Utah Health. And as a reminder, we'll come back and open it up to questions for all reporters. If you do have questions, please put those in the chat box and we will make sure that they are asked. Dr. Narula, please offer your assessment.
Thanks very much for everyone's time and in joining us today for this important discussion. At the University of Utah, it seems that increasingly we have been in a situation where there's been a critical shortage of blood. It seems like probably every other month I get some communication from the blood bank indicating that blood storages are low. The issue, I think, that we're facing at the University of Utah relates to the fact that there's a number of things happening at the same time. The reasons for this are, I think, multifactorial. One, I think we're seeing an increase in our population in the state. Two is, I think that the amount of activity with COVID restrictions dropping and outdoor activities increasing, we're seeing a higher number of traumas this season than we have in other seasons. And I think the other aspect to this is that because our community hospitals are being stretched thin, we are also seeing an increase in the number of patients that we have. And so just by sheer volume of patients, the blood requirements are going up for those patients, even though they might not need large numbers of units on an individual basis. Periodically, patients require blood transfusions for one reason or another while being in the hospital. So I think all those factors combined are resulting in a critical shortage of blood units that we haven't seen like this that I can recall in the state. I've been here now for 14 years. As I recall, we faced a similar shortage at the beginning of COVID, and this was explainable and predictable based on the fact that with isolation, there was a significant reduction in donors. Now I think the problem is a little bit different. I think we still face lower donation rates than we have in the past, but it's combined with an increase in the need for blood transfusions by sheer volume of patients and increasing in activities. At the University of Utah, we haven't had to delay surgeries yet, as far as I'm aware, at least elective surgeries. But I have personally been involved in cases where we're having to make switches or being asked to make switches in the type of units of blood that we're giving to a patient, where it potentially could be some risk to them having a transfusion reaction. We've been able to avoid that, but we've gotten quite close. And it's a life or death call where we're in a situation that we may not have the specific blood type for that person and we're out of O negative blood, and we may have to make a switch. And we at all costs want to avoid that. but we've been close. And so this is getting to the point of, I would say, a critical blood shortage that we as a population have to participate in and trying to rectify through getting more donations.
Thank you, Dr. Nurilla. Now we're going to hear from our major blood supply providers here in the state of Utah. First, from ARUP Blood Services, Deborah Jordan, who's the Community Relations Supervisor at ARUP. Deborah.
Good morning, everybody. Thanks so much. I'm going to piggyback on what Dr. Nurilla said, which is we are at a critical blood shortage. And ARUP Blood Services has one mission, which is to collect enough blood and platelets from our volunteer donors to supply the patients at our local hospitals. And just as all of us are going to say this morning, that nationwide shortage, during this nationwide shortage, it becomes increasingly difficult because we can't rely on those sources that we might have relied on in the past, either surrounding states or neighboring organizations that normally have helped us out. So what we're doing from the blood center standpoint is really asking everyone to come in and donate. And for both of us, I'm sure Benjamin's going to say the same thing. We're doing a call out for O's, O negative and O positive, so we can use that blood during traumas. For our numbers, we've seen an increase, just like Dr. Nurilla said, we've seen an increase in surgeries and a decrease in donations. And we can all speculate that that has to do with our post-COVID life. If you just look on the road and at the airport, everyone is on the road and they're not really hearing our message that they need to come in and donate. So for us, we're looking for donors now to come in and donate.
Thank you, Deborah. And now from the American Red Cross of Utah, Benjamin Donner, who's the Executive Director. Benjamin.
Thank you so much. And as everyone is saying, this conversation is so needed right now. So thank you all. I don't want to be redundant, but at the same time, this need is real. We think about what we need in hand. Blood isn't something that we can store for a long time. This is something that we need to have in the moment that we need it in collecting. And at the American Red Cross, we supply not only here in Utah, but across the country, helping those areas that need it. And when we look at where we are right now, and I'm sure very similar here that Deborah mentioned, we always try to have at least 5 days of supply of blood for these trauma cases, these surgeries, et cetera, and what our hospitals need. We are currently at less than half a day's supply. That, if we think that sinks in a little bit, that's a need that we all need to come together. And in that same plea, that same call to action as Deborah made, we are looking for individuals across the state. Take that time. There's no other way to help these individuals that need it the most. They're still there. They need it. Even in spite of vacations and pandemic, they are still there and they need it so very much.
Thank you so much, Ben. We appreciate it. And again, we're going to circle back and have Q&A. We did want to hear from two of our patients who were significantly and directly impacted by this shortage. David Beverly of Magna, along with his father, Peter Beverly of Taylorsville. They were scheduled to undergo a transplant procedure. And because of the low inventory available at that exact time, that procedure has been had to have been rescheduled and is going to be happening later this month. But again, this is the real impact of patients who are not able to have the care that they need because of this shortage. David, age 31, is donating part of his liver to his dad, Peter, and is waiting to have that procedure done. First of all, David, let's start with you and then we'll hear from your dad, but talk a little bit about hearing the news that you were not able to have that procedure as scheduled due to the low blood inventory.
Yeah, absolutely. Honestly, like, it was stunning. I mean, I've been in quarantine the whole weekend, just kind of psyching myself up for this big surgery. And it was the day before we get the call that there's not enough blood, simply, for us to feel comfortable to go through with this surgery. And from day one, they are all about safety and making sure that you know, we are taken care of. And so I 100% understand. But again, it's just like, wow, like I can't believe, you know, we're that critically low. I mean, it's like, you think, I mean, you never think, you hear from people saying like, oh yeah, we need blood. And you just kind of like log it in the back of your mind. But until you're actually in a situation like this, where, you know, we were ready for the surgery and then told there's not enough blood, you think, oh wow, yeah, we really do have a blood shortage and everything. And, you know, I've literally had to put my life on pause, where my wife and I are expecting a child in September, a little girl. And we had hoped for the June date so that, you know, I would be recovered enough to help her out with the baby, boys as well.
We're going to have a surprise today.
And the way everything is, the way the cards have fallen now, you know, I'm going to be recovering the same time my wife is now after the birth. But, you know, we've made it work. And, you know, when I've been just preparing to help do this thing for my dad, and I've had a small army of friends, family, volunteer to donate blood. They're like, oh, you know, I'd be happy to come and help. And explain to them there's kind of a complicated process to this. You can't just walk in and give us blood for this surgery. That's not really how it works. But, you know, I've been sending everyone I talk to go donate blood because, you know, we're not the only ones affected by this. I mean, we were told there were many other people who had their surgeries postponed or canceled. I'm not sure exactly the logistics, but, you know, I've been sending as many people as I know, you know, dust off those donor cards and donate blood. I mean, we're not the only ones impacted by this. I'm sure there's people in a lot worse situation than we are. And, you know, it's been hard to, you know, kind of unpause life, continue, and then we got to pause it again. But, you know, we're rolling with the punches, hoping that everything works out. We're just, anyone that asks, you know, we implore them to just go donate blood, help people out.
Thank you, David. And when is your procedure rescheduled for? Is it scheduled?
Yes. So we were able to reschedule for July 27th. And so we're hoping everything, you know, works out for that.
Great. And Peter, thank you for joining us. How are you doing?
I'm doing okay. I myself was pretty surprised when I heard that we were low on blood. I've had quite a few people ask if they can donate, and I just send them up to ARUP and say, go take your family with you, take everybody, because this is serious. So we're just taking it a day at a time. Some days are good, some days are bad, but it is what it is, and I'm totally amazed by the team that they have in that transplant center. They're awesome people, and they do anything they can to help you out.
Well, thank you for joining us. We appreciate it. Sit tight. We're going to have, I'm sure, some questions for you. But let's go ahead and do open it up to questions and answers and address some of the questions that have come in so far. Dr. Narula, let's have you take this one. I know you posted some of your answer on the chat here, but let's go ahead for everybody who may not see that. The question was from Sean Means at the Salt Lake Tribune. Some straight numbers. Tell me, how many pints of blood do you need on hand for a typical cardiac or transplant surgery? And also, how many donors would you need to say the shortage is filled? And it sounds like this is an ongoing situation that probably is going to last the summer. Can you address that as well, Dr. Narula?
Yeah, so as I mentioned in the chat, you know, a cardiac surgical case may require 5 or 10 units of blood if things are straightforward. If it's more complicated, it can be much more than that, 20, 30, or even 40 units of blood. And in certain cases where the surgery is quite complicated, that's not uncommon. we try to take steps to conserve patients' blood. We use in the operating room techniques like cell saver, where when blood is shed, we collect it and we process it and we give it back to the patient. But even when doing that, there's still a loss that we can't keep up with. In liver transplants, depending upon the nature of the transplant, it may be a relatively low blood loss, only requiring a few units of blood, or it can be quite significant, again, getting into the teens to 20 units of blood and blood products. And for a bad polytrauma patient, you may start off with needing 3 or 4 units of blood, but then if the bleeding is significant, it may be as much as 30 or more units of blood. And that, fortunately, those kinds of units, that kind of need doesn't happen that often, but given that a typical donation is really only 1 unit of blood at a time, if you have a single badly injured trauma patient, now you're down 40 or 50 units of blood, and then all it takes is 1 more, and the next thing you know, you're in a shortage where we can't keep up with the need, and so that's why some of this is quite unpredictable in terms of what's needed. And in the summer months, our trauma volumes are always up, and so the need is high.
Thank you.
Jess.
Yes, go ahead.
Just kind of bring that together then, as far as in the setting of David and Peter's experience. As was shared, you can have a trauma patient that requires quite a bit of blood. And we had a weekend in which, on average over a month, we can use 1,800 units of blood products. And in just one weekend with trauma patients, we had 477 units. And so with that supply not being there to replenish what was used, going into a day then when we had this elective transplant procedure scheduled with David and his father, Peter, we didn't have a safe amount that would be on hand for such a situation. Fortunately, we typically will use only 2 to 4 units of blood products during a transplant, but as was indicated, you can require up to 20 if in certain scenarios, and we did not want to go into that procedure in an unsafe fashion.
Dr. Ferguson, while we have you, a question from Jed Bull at KSL Channel 5. Have you seen this type of blood shortage before in your career? Is it comparable to something you've seen? And given all the factors, the coming out of the COVID pandemic, travel as the quarantines are lifted, trauma season, all those factors come together, how concerned are you for this summer moving forward? Because traumas are only going to increase as more and more people are out and about.
That's a great question. I really have not seen a perfect storm like this before. We did have a scenario in which there was a specific shortage of platelets, in which we were having to then carefully manage procedures that typically require that blood product. But this is a very concerning scenario. As was indicated, we anticipate that through the summer, this is going to be a concern that will be a background stress for us. And so the number of donors that we have staggered throughout the summer is going to be very important to be able to get us through the typical trauma season that we see, in addition to still being able to care for other patients like our transplant and cardiac patients. I am, however, very optimistic because of the fact that so many good people are willing and ready to come and answer the call when they know that the need is there.
Thank you. And a question to our representatives from ARUP Blood Services and the American Red Cross from Sean Means at the Salt Lake Tribune. He asked, pre-COVID, how many donors were coming to ARUP or the Red Cross in an average week? And how many donors have you been seeing averaging lately? Let's have Deb, if you could take that one, and then Ben, if you could follow up from your perspective.
So pre-COVID, we were seeing about 75 to 100 donors a day, and that allowed us to keep our blood bank pretty well stocked for our patients. Now this summer, as Dr. Ferguson said, it's a bit of a perfect storm. We're seeing closer to 50 to 60 donors per day come through the door. So we do need to sort of find a way to backfill a little bit and to think about the future, because those people who donate today and tomorrow, their blood will be on the shelves in August. So every single day as we make some headway on it, it really helps us out. It helps the physicians out.
And Ben.
Yeah, no, Deborah hit it right on the head there, as that need is going to grow. With the American Red Cross, a little bit different, and we have anywhere from 10 to 13 drives happening out in the community every single day, in addition to our blood centers. So there really isn't an average, a specific average, because that ebbs and flows. One stat that I just read that I thought was fascinating, as we look across the country, over the past 3 months, we've distributed about 75,000 more blood products than were expected. And you think about that, where you do everything you can to work with our amazing partner hospitals to have that precise number, exactly what we need, but that need has grown so much that it feels like we're continually playing catch up here. And we have all of those blood drives in place. We have our blood centers. Everybody can see where they're at and go donate. It's just making that a priority, helping them to remember, individuals such as Peter and David here, that they are still sitting there. That need continues every single day.
And I feel kind of optimistic about it, like Dr. Ferguson and Dr. Narula, which is, this is what we do best here in Utah. We really take care of our communities. And when that call goes out, we really do see donors come through. And so I think having a press conference like this where the media can help us with those call to action, I think it will really help. But I'm optimistic about it.
So well said, Deborah. Thank you. I agree.
Question from Sean Means from the Tribune for Dr. Narula and Dr. Ferguson. He says, we were told last week by the Utah Department of Health that many hospital procedures that were put off, deferred because of the pandemic, are now being scheduled. How has that affected the drain on the blood supply? So that perfect storm that you talked about, Dr. Ferguson and Dr. Narula, what role is now doing those procedures that were rescheduled or deferred during the height of the pandemic? Dr. Narula, let's have you go first, and then Dr. Ferguson.
Well, yeah, so certainly the volume of surgery correlates with the number of units of blood that we need to use. So when the pandemic hit and then we had another blip recently, we were looking at potentially having to slow down on our elective surgeries, which had we done that, I think would have had a very small effect on the blood utilization because of the nature of the surgeries that would have been stopped. We wouldn't have stopped doing semi-elective or more urgent surgeries, and those are the operations often that require the most amount of blood. Transplants often will happen in an unscheduled way, and they're another example of cases that require a lot of blood. And so had we put a slowdown on elective cases, I think it would have only had a minimal effect on our blood utilization.
Thank you. Dr. Ferguson?
I'd agree with that. You have a scenario in which we need to be sure we're clarifying also that we had to last year as well. When we say elective, elective procedure does not mean that it is not required. It's not a surgery that is required in order to help that patient overcome the current medical condition that they're in, but rather we can schedule it in an elective or a controlled fashion as opposed to an emergency where someone comes in bleeding from a trauma procedure. And what we're seeing then with these elective procedures isn't so much a backlog of the surgery itself, where patients during the time that we just did not have hospital capacity and we're having to judge which procedures really needed to go right then and which patients were able to get into a limited number of beds because of that surge of COVID. It's more along the lines of those procedures have already taken place. However, you do have many patients who had delayed diagnostic procedures. And so we're seeing many patients then that are getting their screening colonoscopies, their mammograms, going back in to visit their doctor and finding out a certain condition has become worse. that is then requiring a consultation with the surgeon and is being found to be in a condition in which surgery is required to help them improve. So I want to be sure to clarify two things. One, elective, when we say that, many times people think an optional surgery that's not really needed. No, that's not the case. It's a surgery that can be scheduled in a controlled fashion. And then the other issue is that we don't have a backlog of surgery that had to be postponed because of COVID, but rather what it looks like we're seeing is a resurge of individuals going to their physicians, getting diagnostic procedures, and then being diagnosed with a condition that does require surgery that has caused an increased wave of volume of surgery that's required.
Thank you for that clarification. David and Peter, a question for you from Haley Higgins at Fox 13 News. Let's see here. David, you are donating a liver to your father, Peter. Peter, can you talk about the need for your transplant and what you would tell people who may be just not thinking about the need for blood right now? Can you address that? What's your need for a transplant, and what would you offer to people who are just not thinking about it, but who could really help?
Sure. I have non-alcoholic liver disease, and it's to the point now where I have to be treated for the toxins and stuff that are getting into my system. Because of that, it makes me sick. It didn't happen just overnight. It's taken a while, and when it does get to you, it knocks you down. That's the main reason I'm having it. And I'm one of the luckier ones that have a close family network that can help with that. And get me through that, along with good doctors and surgeons and stuff.
And a great son.
Yes, a great son. And they want to know how old I am. I'll be 60 in July.
Thank you, Peter. David, just talk about how watching your dad in this situation, how you're eager to have this procedure so that he can start feeling better.
Yeah, absolutely. So I'm the youngest of 4 kids. Got 2 brothers and a sister. We had all come together after it was after a little while of him being sick that we all kind of got together as siblings and had a discussion about, what we wanted to do. He's a grandfather to many sweet kids. I myself have 2 boys and a girl coming on the way. And man, they absolutely love their papa. And, and I love my dad. And, we all came together to see what we could do to help him out. Because, he can't really go out anymore. He's, as he mentioned, the toxins require him to flush it out of his system. And so he's at home the majority of the time. He can't really go out. We came together as siblings to see if any of us were a match. And it was absolutely zero pressure. We totally understood if no one didn't want to do this. But my sister and I both ended up opting to try. She was eliminated pretty early on because it's pretty rigorous stuff that you have to go through. I honestly didn't expect to make it this far. I didn't know how compatible I was going to be, but I really wanted to try. And I kept going. They kept giving me more appointments. They never said no. And then we get to the day where, yeah, you're a match. I'm like, oh, wow, all right. And let's do this. And I'd love to be able to do this so that, my boys can, and my incoming daughter can have a grandfather that they can look up to in the coming years. So.
Oh, thank you for sharing that. Just a couple other questions and we'll be finished here. But Deb at ARUP and then Ben at American Red Cross Utah. So how do people find out about their eligibility, if there's restrictions? There was a question about, are patients reluctant to receive donations from donors? Has the COVID-19 vaccine played a role in that? Are you hearing kind of that feedback? Deb, let's start with you and then give out your resource for people to find out more information about ARUP donations. And then Ben will have you address the same thing. Deb.
We haven't heard any feedback about patients not wanting to get blood from donors who have the COVID vaccine. From our standpoint, having donors who have or haven't received the vaccine is fine for both of us. There's no restrictions. The FDA regulates who can donate. So there's lots of information on both of our websites at utahblood.org and at an AmericanRedCross.org, redcross.org. It's, there's lots of reasons why you can't. There's medications. You might've just had a surgery. You might've traveled to a country, but you can also just call both of our organizations and talk to a staff person and run through your scenario. And then you get individualized answers. And Peter and David are a really great story to put all the puzzle pieces together, which is it's not just acute trauma that is requiring blood donations and platelet donations, but imagine too that there's cancer patients who need treatments every single day. That hasn't stopped during COVID. It's hasn't increased in our little post-COVID world, but I was recently treated at Huntsman for the last year, and I'm in that same bay where people are receiving blood and platelet transfusions, and those patients need this kind of blood for life-saving measures every single day. So it's putting all those pieces together for our donors to make sure that they understand why they're donating. Thank you,
Deb. Ben.
Yeah, this is definitely something that I would agree with Deborah. We have not received a lot of feedback with regards to reluctance there. In fact, most of whom I've spoken with have said they are more engaged, et cetera, about this and in trying to help those with antibodies, et cetera, et cetera. At this time, with regards to that eligibility, just as Deb mentioned, redcrossblood.org, like she mentioned, we are FDA regulated across the board. So that information should remain constant with regards to that eligibility. Just being able to know it is safe. That was one of the big questions early on. It is safe. It is important to come together to manage this. I appreciate Deb's story there in her being there. A couple of years ago, I found myself in the emergency room of a hospital. I was one of those trauma patients that needed 4 units of blood in the moment. And I think about how it is right now with as little on the shelf as we have. We're optimistic, but in that moment, what if it wasn't there? How would I answer my then 13-year-old, my 11-year-old on where does that blood come from? So just thank you so much to everyone for being a part of this.
Well, thank you to all, Ben. Thank you. And thank you to Dr. Ferguson, Dr. Narula, Deb Jordan, Ben Donner, and to the organizations Intermountain Healthcare, University of Utah Health, ARUP Blood Services, and American Red Cross who have come together to get this message out. And thank you to members of the media for joining us to help us get this message out and to encourage as many people as we can to donate blood during this important time. A special thank you to David Beverly and his Father Peter. We wish you the very best for your upcoming procedure, and thank you for joining us and sharing that personal perspective of how this inventory situation has affected you personally. We appreciate your time.